record to the computer. Okay, so next Monday, you guys get to sleep in a little bit. I'm gonna do, I made it asynchronous and so that topic is, I feel like the topic that's next week is kind of like a little easier. It's not actually a really great topic because it deals with child abuse, so it's kind of a little bit sad of a PowerPoint, but it's I'll do a recorded lecture, so listen to the lecture and don't forget that there's a 5-point discussion. So I have a due date for the 5-point discussion. I think it's by the end of the week, or I can't remember what I put it, but just don't forget that that content will be on an exam and there's a discussion to interact with. So just because, it's easy when the class gets like put in a different format and then you kind of it's like it vaporizes, you forget it's there, but there is still stuff to pay attention to, even though we're not going to be meeting next Monday morning. So no physical class, but there is some stuff to do. Okay, so I said that out loud. Everyone witnessed it. Okay, so renal disease and organ transplant. So we talk a little bit about solid organ transplant. We're going to talk about dental management considerations for kidney, end-stage kidney and transplant. Compare and contrast chronic kidney disease and end-stage renal. Some of these objectives are way too specific. I don't think we go into that deep, but we do talk about some things that happen toward the end. Dialysis treatment, various secondary medical conditions that are very common for people who are in some kind of organ failure, especially kidney organ failure. And then it highlights the big take-home point here is that somebody that has an organ failure, whether it's their liver, heart, lungs, kidneys the most common, they're going to be seeing a lot of different kinds of healthcare providers. They're just going to see it. So the interprofessional piece is just, they're going to have all kinds of dietitians and, nephrologists and different, their regular doctor, and then other specialists. If they have heart conditions, they'll have a cardiologist. I mean, there's usually a case manager. They usually literally have like a team of people. So there's just a lot of interprofessional things to think about there. And the biggest thing is you won't see very many like really sick patients that are about to have a transplant, but you certainly could see a couple throughout your career. So the big thing to remember is this is going to feel like a new thing, and never feel like you can't reach out, confirm. Like it's one of those things, if you know your patient's coming up like the night before, the day before, you'd work up your sort of case about it. Think about what they need. Maybe the doctor will have been contacted, and whether that you need to worry about something or whether it's not a big deal. Everything's fine. They're stable. All their numbers are good. So you just want to remember that you can always be a part of that interprofessional team and find out what's going on and what you need to be concerned with. Okay, so solid organ transplant, it's a surgical procedure where they take, a viable functioning organ. And these are the main ones: heart, liver, pancreas. I haven't heard much about that, but that's included. Lung, intestines, bone marrow. We hear that fairly commonly with cancer patients. Kidneys are by far the most common. And it's placed in a patient that's at an end stage of their organ is failing. So the recipient obviously is the person that needs it, the appropriate patient. And then there's the United Network of Organ Sharing, and then Oregon Procurement and Transplant Network. They're nonprofits that sort of try to manage this so that organs don't become like a black market commodity, which sadly you can hear things about that being the case, and sometimes in other countries, and who knows, how big of a problem that is, but there are long wait lists for people who are looking for organ donations or who need an organ donation. Okay, so just lots of reading on this PowerPoint. There's just a lot of things to kind of summarize. So renal is for a kidney, the average kidney patient waiting for a deceased donor usually is on a wait list for about 2 years. Unless you have a family member that fits your type, like unless you match with your brother or sister or uncle or whoever. Transplants are more common due to clinical advances, so they've gotten better at it, so they do it more often. Variation in patient care and hospital recommendations, so there's not really a cookie cutter way of doing things. They there's maybe different philosophies. Major medical advances in organ transplants have occurred mostly because they've gotten good at suppressing your body's desire to reject a foreign thing. So they've advances in pharmacology have made it so our bodies don't reject whatever they're transplanting as easily. And then acute organ rejection is relatively rare occurrence in today's world in advanced medicine. Sepsis, chronic rejection continues to threaten the patients who've had it an organ transplant. And sometimes there's a woman in my church who had her she had a liver transplant, and she's been I think she's like on 5 or 6 years now, and she's starting to have problems. So her liver numbers were going crazy. She had some other chronic issues. And so you just, you don't know like how long maybe it would be successful or what other kind of secondary thing could start, happening. So they're not typically maybe like always the healthiest after, they try to live a normal life and be healthy, but there can be complications. Um, Managing oral health before transplantation. So oftentimes it's about, and this is true for the same with cancer patients, it's about before they get treatment, getting them as healthy as possible, trying to eliminate that's sort of the like it in a nutshell is eliminate infection, eliminate potential infections, and just and get them as healthy as you possibly can prior. So consult with the patient's transplant team. I bolded some of these keywords, the patient's overall medical status to establish whether the patient is able to tolerate dental or dental hygiene. If they're end stage and they're super sick, maybe they just can't, or maybe they're going to arrange for you or the dentist to come into the hospital, or if they're on, at home in bed or something waiting for a transplant, maybe you'll be arranged to go, or they'll try to find a hygienist or a dentist who can go and do that service at their house. So who knows how it would happen, but you have to sort of get some clearance, postpone dental and dental hygiene treatment when necessary. So they want to get all the infection out if they can, but at the same time, they might be limited. Consider the need for antibiotic prophylaxis. This oftentimes just depends on how much infection and what kind of a risk. Consider the need for the patient's bleeding. We talked about the bleeding disorders. Lots of medications can cause, thinning of the blood or platelet activity or coagulation changes. And oftentimes, if they are on dialysis, they'll be taking some kind of a blood thinner. Pre-transplant patients may be taking multiple medications, lots of other comorbidities. So you just have to be really aware of that, thoroughly review their medical history, thinking about all the side effects of all the many different drugs that they could be on. And sometimes they're pretty common drugs like high blood pressure medications, or, they could also be a diabetic. And so some of that stuff wouldn't be like crazy weird, like I've never seen this drug before, but you just have to kind of take them all into consideration. Emphasize the importance of good oral health always. That's, one of the biggest things to try and get their mouth as healthy as possible, even if they still are in need of like a deep cleaning. Even if someone has a lot of calculus, obviously they're not going to get all that inflammation won't necessarily go away, but if they get really good at oral hygiene, things can improve a lot. Managing oral health after transplantation. So we kind of have this 6-month window when they're going to be very fragile. They're going to be with their doctor a lot. They're trying to make sure that the organ's not rejected. And so really there's no dentistry or dental hygiene before 6 months. You will obtain medical clearance to make sure that they're ready and stable and everything. And I highlighted it here and I say it later in the PowerPoint, but and I was gonna look up the med because this happened to the lady in my church. There's mostly it's due to, I think, the immunosuppressant drugs, but organ transplant recipients have an increased incident of squamous and basal cell carcinoma. And I put due to specific anti-rejection drugs, but I think that I think it's specifically a certain type of immunosuppressant drug. But she ended up with, I think it was some kind of a squamous cell um, carcinoma, and her doctor told her it's due to the drugs that you take to keep your body from rejecting the liver. So it's very common. Consult with the patient's physician to discuss appropriate selections, dosage, administration of any kind of drug that you might have to give them. So, you know, if you want to get them numb for SRP, you might just want to reach out and be like, can I do 3 carps of this? You know, just to give yourself peace of mind and just to find out that the doctor kind of gives that okay. Or can they take NSAIDs? Can they take Tylenol? Can I give them an atolol? Like whatever. What can we do? So we just want to kind of have that covered. So common drugs that they'd be on. The one that I think the two probably, I hate saying this because I'm always like, what if I forgot what I put on an exam? I feel like the most common that I would probably put on an exam are cyclosporin or prednisone, the tacrolimus, the mycophenolate. I don't know, but I do know that I have talked about and I've seen. I feel like those are the ones, those are very common. You might see those more likely. So I feel like I'd test on those more if but just don't hold me to that. Okay, and then so risks for the patient, nephrotoxicity, long-term complications of bone metabolism, adrenal crisis due to high doses of prednisone or corticosteroids, and then the cancer risk. And then nephrotoxic, wide variety of over-the-counter and prescription drugs, along with common herbs, can endanger a patient's delicate balance. They're just more fragile in general. They're taking meds that weaken them in order for their body to, deal with this transplant. So they're just a more of a systemically fragile person. They're not as robustly healthy as someone that doesn't have to deal with any of this stuff. Okay, so the medication side effects. So immunosuppressive drugs can potentially cause gingival hypoplasia. We've seen that before. I think we touched on that in pharmacology. Poor and slow healing, drug-induced liver disease. So the liver has to try and metabolize and process all these drugs, and it can be very hard on the liver. And interact with commonly prescribed medications. Immunosuppression may result in increased risk for opportunistic infections, basically is what that's saying. Anticoagulant medications may contribute to excessive bleeding. So you want to think about that if they've needed some kind of like the INR or prothrombin, or just, again, take those principles of starting the area of least inflammation, kind of test the area, see how their bleeding is. Patients taking steroids are at risk for acute adrenal crisis, especially if it's a high dose over a long period of time. So for kidney transplant, again, like I said, largest population of organ recipients is the kidney recipients. Dialysis is something that somebody could be on for years. It's called the bridge to transplantation. So once you're on dialysis, your kidneys are not doing well. And so you have to have this blood cleaning process a couple times a week. Usually, so cleaning and filtering waste and toxins from the blood, removes salt and extra water, maintains safe balance, helps control blood pressure. Remember the renin system, the kidneys are like super important. So you play a super large role in maintaining blood pressure. So if you have kidneys that are not functioning, then you undoubtedly have blood pressure issues. Deceased or live donor for the kidneys. So the kidneys are unique because they have this 48-hour window, a much greater prevalence than other organs. Like somebody could have, passed away in a car accident, and then the kidneys could be put, if they donated, if they were an organ donor, their kidneys could be donated up to 48 hours later, which is pretty amazing. Not all organs can do that. Okay, so for gingival enlargement, side effect of immunosuppressive therapy, poor oral hygiene, increased sensitivity to cyclosporin, associated with medication, also the tacrolimus, which there was another name for it, Prograf. I don't know if that would help you remember at all that it can be attributed to gingival enlargement. Transplant physicians reluctant to change. Most physicians of whatever medication that they have that is increasing gingival and like hypoplasia or gingival enlargement, if the medication is really controlling the patient's chronic disease, they are not like, oh my gosh, big gums, we got to take them off this, we got to take them off this drug and put them on a different one. Like they're just not, it's not a high priority to them. And so you kind of have to like understand that going in, but you should certainly talk to the physician, be like, hey, I'm a dental hygienist working at this practice. I see this, our mutual patient, blah, blah, blah. And they have significant gingival hyperplasia, and just talk about how it affects the mouth. These are the things that can improve. Are there any recommendations that you have, or should we just stick to more frequent cleanings, encourage the patient to have better oral hygiene, and just have that conversation with them, realizing that they're not necessarily going to take the patient off of the med. Beep, beep, boop. Was that? Am I on a different one? Oh, no, that is it. Okay. Most transplant recipients are treated with multiple immunosuppressants. So this is a trio of immunosuppressants, cyclosporin, prednisone, and then this mycophenolate mofetil. So those are, I guess, very common, but there's certainly probably other cocktails that they might receive depending on the doctor. So for our role, we want to really focus on their oral hygiene, really try to get them in good habits, focus on like one really good tool at a time. Don't overburden them, but say, let's perfect your brushing. Now let's add an interdental. Now let's get you to do this or whatever it is. Frequent debridement. So oftentimes, even if they don't technically have deep pockets, you certainly might want them to come in every maybe 3 to 4 months. And then be aware of how the immunotherapy can mask inflammation. So there are, the corticosteroids, it can cause the tissue to not look as red and puffy, and they can still have deep pockets and bone loss, active bone loss. Any infection can be a reactivated or exacerbated event. So especially, so if somebody has like bad perio and their body's trying to maintain this new organ, it can certainly be a bad thing to have that happen. So that's why, any infection anywhere is going to be a problem, but oral hygiene, of course, is our area where we care the most about. So, okay, dental hygienists should educate patients about the potential risk for dental infection and play and the role it plays in organ rejection and infection. It's just, I don't like that sentence, but basically it's just talking about the patient and the connection of the oral mouth and oral health to systemic health. The blood that circulates through your mouth, that infection that's raging in your mouth is circulating through your whole body, and undoubtedly will get to that organ that is weaker, and that that they're either going to have a transplant or if it's a new organ. So just kind of helping them connect the pieces, like this is not a separate thing. Your mouth is not like getting your hair cut. It's like integral into your whole body. So really helping them understand that. Pre-medication, maybe yes, maybe no. Really just depends on the patient, depends on how sick they are, depends on their doctor. So you just have to sort of wait and see. I've had patients that were on dialysis, and every single time they came in and had pre-med, and that was just per their doctor. And I saw the record of it, and so I would just check, did you take your pre-med? Yes, I did. So it just depends on the doctor. So you have to just always have that be a red flag, and then find out what the protocol is. Majority of medical providers recommend antibiotic prophylaxis for invasive dental procedures, which of course a cleaning is an invasive dental procedure. Individuals evaluate each transplant patient and and you're going to consult with the doctor. So considerations, if or when to receive dental treatment. So these are kind of sort of summarizing it. Can they have it? If they can't have it right now, when's the soonest we can? Keep checking. Don't let these patients fall off of your books. Try to, you want them still to be healthy in the oral cavity. You want them to have full body health. So you don't want to just sort of forget them and leave it up to them, check in with them, especially if it's a patient that you've seen for years. And then all of a sudden they're going through this really big thing. And, you want to check in with them and not hound them, but make sure that they don't fall off and just, go longer than maybe they could come in sooner. Comorbidities, always have to think of that. How medically stable are they? Patient medical management pre and post transplant. So just think about what they need to have done and what they're going to have done afterwards, and always paying attention to the meds that they're taking. They're going to be more at risk for those opportunistic infections, the squamous and basal cell carcinoma. Patients that have a liver transplant likely have a history of tobacco and higher alcohol consumption. Not necessarily everyone. There could have been hepatitis C. There could have been, any number of things. It could be some kind of a genetic weakness, or who knows, I don't know, but very likely that's something you just want to rule out. Immediately after transplant, only emergency dental care. So we have that 6 months window that we have to wait for. Also, patients who have kidney disease, very likely they might have these other comorbidities: diabetes, high blood pressure, cardiovascular disease, obesity, and probably a family history of chronic kidney disease. That's CKD, chronic kidney disease. Okay, so for the stages, you do not have to memorize perfectly these GFRs, these numbers. Knowing that there's stages, knowing that there's 5 stages. On the take-home quiz, there is a question about the stages. I think it's good to sort of read them through. I do not believe that I have a question that would be super specific on any of these. But I will double check. But I don't think I'm going to tell you now that you don't have to memorize the numbers that correlate with this. Just the fact that just the general categorization and the stages, but you don't have to memorize the GFRs. Okay, so systemic conditions. So this slide has a lot of important information on it. So somebody with chronic kidney disease is very likely going to be suffering from anemia. They are going to be at much higher risk for infections. There's a couple things going on systemically. So low calcium levels and high phosphorus levels in the blood. So a lot of times there's bone issues, and we care a lot about bone, right? Because we're always thinking about periodontal disease and the bone around the teeth. So there can be some issues with their bone development, or the osteoclasts and osteoblasts, and just losing bone faster. High potassium levels in the blood, that's hyperkalemia. So that can cause irregular heartbeats, irregular pulse. There's another thing down here, or it might be another slide, about calcium buildup also in the arteries, but loss of appetite, excessive fluid in the body causing high blood pressure, swelling. So swelling in the legs, that's just sort of your edema. It's just the when you think of swelling in the legs, but then can also be pulmonary edema. So that can affect patients' breathing, the comfort of them laying back all the way, that weight of their chest can make it feel even harder to breathe. Depression, low quality of life. There's obviously they don't feel well a lot of the time, so that's going to affect their mental health. Certainly more likely to die sooner, and likely to die from a heart attack or a heart disease or a stroke. So then there are these sort of secondary medical conditions. I consolidated 2 PowerPoints, so this might be a touch repetitive, but secondary medical conditions are not part of the original etiology of the disease, rather a complication of the development of their organ not working well. So the organ starts to fail. And then when that organ fails, it's going to affect all these different body systems. So everything, depends on each other to some degree. So once you have one organ that's like, peace out, then the other ones are like, ah, and then it's kind of a cascade. So fluid retention, anemia, hyperparathyroidism is another one, malnutrition. There's just lots of different systems that will can be affected. So that's part of the necessity for dialysis again. So this just sort of reiterates a little bit of what we talked about earlier. Dialysis is the treatment method for cleaning up the blood when they're waiting, when they're in end stage, they're waiting for a transplant, removes the salt, excess water, maintains a safe balance of the chemicals in the blood, helps reduce blood pressure. Basically just a repeat of the earlier slide. Okay, so some practical things highlighted here. Hemodialysis, there's different kinds. There's this continual ambulatory peritoneal dialysis, continuous cyclic assisted peritoneal dialysis. You don't really have to memorize those differences, just knowing that there's different approaches. Usually people will go to like a dialysis center and they'll go there and all they do there is deal with kidneys and dialysis. Consult and obtain clearance from the nephrologist. Usually the patient, I remember one patient I had for years in a general practice I worked at, and she every other day except for on the weekends. So she always went for dialysis like Monday, Wednesday, Friday. So she could only have her cleanings Tuesday, Thursday. And she would come in and she would say, she would announce, she was so used to doctors and how things were that she would basically just tell us this is what's going on. And so there, and we saw her so frequently that, she had like a book of a medical history. I mean, it was just crazy. But she kept us really well updated. And if we had any questions, then we could always call her doctor to check in. Do not take blood pressure on the dialysis access. So the arm that has the port, do not take blood pressure on that arm. Take it on the other arm, obviously. Avoid dental treatment day of dialysis. So like we said, so she'd go in, Monday, Wednesday, Friday. We would only see her on a Tuesday, Thursday. Okay, so I highlighted these because every time I ask questions on exams and especially like this uremic frost, it's like it disappears. Nobody ever saw the words. And then afterwards they're like, what's uremia? What's uremic frost? So I highlighted it. So you guys know there's probably gonna be a question on it. So anemia is very common, reduction in mass circulating red blood cells. Nearly all people with end-stage renal disease have some form of anemia. And the anemia, there's lack of red blood cells, so their oral mucosa might have this pallor look to it, paler. So that's what that means. Pallor of oral mucosa, kind of a paleness due to the anemia. They might have glossitis, they might have recurrent aphthous ulcers, they might have Candida albicans or some other opportunistic infection, such as also fungus is or the yeast is that angular cheilitis. So white patches or uremic frost is actually like a depositing of stuff from that the kidneys couldn't filter out. So the kidneys aren't functioning super well. And so like your skin, which is your largest organ, sort of has to like do some of the work. And so it will excrete some of these, calcium, phosphorus, whatever salts that the kidneys can't do. And so that's why it almost shows up as like just like on a frosty morning, right? So that's what uremic frost means. Yeah.
Is that like external or is it in the oral cavity?
Both. I think it can be both. And good question. And I think there's another slide. I had a whole table with like tons of information and I just felt like it was overload. And so I tried to pull out what I felt like was the most, but I have the slides hidden. And maybe it would say it there, but I think I have another slide where there's some notes. Possibly poor oral hygiene due to fatigue. Obviously, like we talked about, they're not going to be the healthiest patients. Increased calcium formation. Again, kidneys not able to kind of process all the things. And so calcium deposits and things like that will increase. Osseous changes, again, due to those phosphorus and different imbalances. Dysgeusia, taste, different, like a bad taste or alternate different taste in the mouth. Petechiae, ecchymosis, and gingival bleeding, potentially from medications that they're on. Okay, so mineral and bone disorders, excessive secretion of parathyroid hormone. So then they can have so they can have some conditions affecting their thyroid. Kidneys lose ability to excrete phosphorus from the body and produce active form of vitamin D, which is super, super important. Like almost every cell in our body has a receptor for vitamin D. And so if their body is not able to produce, like that's the only way we get vitamin D, right? Is from like the sun, like we make it. And so that's why we supplement it. So if their body can't make it, then they have to have a supplement. Must limit phosphorus intake, vitamin T supplements and phosphorus binders, because they can't excrete the phosphorus. So they have all of this difficulty balancing all these things in their body. Renal friendly diet. So they oftentimes are working with a nutritionist. So for oral manifestation, calcium deposit on the teeth, soft tissue, vasculature and organs. So, you could potentially see like that calcification on the carotid artery when you take a pano, and they could have other manifestations in their mouth. Calcium deposit in the carotid artery. Okay, I said that. Narrowing pulp chambers. So they could have like a buildup on the inside of the pulp chamber, making their pulp chamber smaller and smaller. So weird radiolucencies, calcium's going to show up more radiolucent on no, that's opposite. It came out of my mouth. I was like, no, that's not right. It would be more radiopaque, so radiolucencies might be because of the bone issues that they're having. So they could have some resorption happening somewhere because of the balance of calcium and phosphorus and just different elements of their bone. Loss of the lamina dura, the trabeculation pattern, and then the bone density changes. So you're not being tested on like why all of these things happen to the the hill, because that's just a lot to understand. Like the process of exactly why the bone density changes would be probably a lecture in and of itself. So I know sometimes this information can just it can just ignite questions, which I think is fabulous. And you can always look up that information for your own, especially if you have a patient that comes in and they're an organ transplant patient, or they're in end stage renal disease, and you see some of these things and you're like, what is going on with this patient? You can become like a little mini expert and talk to them about it and learn more. But it's too much stuff to try to get you guys to get a full understanding of why all this happens. So it's just things to be aware of that could happen with these patients. Oftentimes they're working with a nutritionist. There's oftentimes a renal diet. They have to watch their sodium intake, their fluid intake, because they're not going to get rid of fluid as easily. So they can't just be gulping water. So when we have patients that have xerostomia and we're like, sip water all day, we can't say that to our kidney patients, because it's going to be different for them. Limiting dietary phosphorus and potassium. Consult with a nutritionist about products that they can ingest. So you might recommend xylitol, but you might say how much xylitol would be safe for them. Too much xylitol for anybody will kind of give you the runs. Did anyone know that? It's like a laxative. So most people don't want to eat gobs of xylitol, but it's probably a good thing to just check with the doctor. Protein levels may be higher or lower depending on where they are in their disease. Uremia compounds the dental calculus problem. Now I had producing nitrogen. As kidney disease progress, nitrogen materials accumulate in the body, producing a condition known as uremia. So they're not getting rid of stuff the way normally our kidneys would cleanse everything, our blood, we'd pee out the excess salts and things and all the different chemicals and the excess fluid, and they just can't do that as well. So then they get this buildup. Salivary pH, uremia alters the pH of the blood. It alters the pH of saliva. And then there's debate about whether or not that's a good thing. Like if they have a more basic saliva, maybe they won't have as much decay. So you can find articles about the pros and cons, like more calculus buildup, more basic saliva, like are there pros and cons to it? So with xerostomia, there's nothing that contraindicates xylitol, but you probably just want to check on the amount. Frozen grapes, power toothbrush, the saliva substitutes. So they're not ingesting water, they're using like a saliva substitute. Sleeping with a humidifier. So for professional recommendations, gustatory is another word for taste. So stimulating their taste. So with sugar-free gum and candies, that can help stimulate saliva as well. Mechanical stimulation, power toothbrush, xylitol containing chewing gums and lozenges, foods such as apples, carrots, and celery. That's all going to kind of stimulate salivary flow. Pharmacologic stimulation, the pilocarpine HCl, and then that other one, the sevomelain. I don't know. I haven't heard of that one before. I've seen the pilocarpine a lot more. Over-the-counter salivary substitutes, chewing on ice as long as they're not getting too much fluid, and then the humidifier. That's sort of just a repeat of what we said. So for periodontal disease, there's sort of a general understanding that yes, they probably are at a much higher risk for periodontal disease, especially if it's somebody that has chronic kidney disease. Maybe not so much if they are getting a lung transplant or they're getting a heart, and that's why we don't really focus on any of that. This PowerPoint, if you noticed, it touches on in general patients with an organ transplant, but it really highlights kidney disease because there's just so much more about kidney disease that's going to show up in the mouth. So in general, there's studies that sort of indicate that yes, they're probably, but the relationship isn't as well defined as much as like diabetes is very well defined. So the risk of periodontal disease appears to be significantly increased, especially with those with severe renal disease, increased calculus formation, potentially more non-compliance, or just not able to get into the office. Like maybe they're just in tons of doctor's appointments. Maybe they just have low energy. Maybe they're in the hospital, so they just can't get to the dentist. Exaggerated inflammatory response associated with alteration in host defense mechanism. Secondary hyperthyroidism may contribute to accelerated bone loss in the presence of periodontal disease. So if we can see them, we want to see them more frequently. We'd want to see them on a 3 to 4 month basis, and always coordinate with the whole healthcare team with anybody who's having a transplant, but especially if they're having a kidney transplant, you'll just know that there's going to be more oral considerations as opposed to someone's having a lung transplant or something like that. And these are just some people that you might see: nephrologists, nephrologists. I don't know why my brain isn't working the words are slipping. Nephrology nurse, renal dietitian, nephrology social worker. So like a whole case manager probably to coordinate all of these appointments and people and, doctors and medications and things like that. Patient care technician, pre-transplant and post-transplant coordination team. So probably different people before, during, and then after. So just a lot of healthcare providers in the mix. And so knowing when the patient comes to see you, they're probably just so used to seeing people, so used to being told things that, you kind of think about, how will I talk with this patient? How will I connect with this patient? And maybe it might be more of like how are you? How does your day-to-day life look? And how can I assist you in having the best oral hygiene through all of this all of these things that you have to do, all these appointments that you have to go to. How can I be an assistant? How can I help you set up a good routine or prioritize something? So a lot of empathy and understanding, but also building some knowledge around the patient and what their life looks like. Okay, so I went really fast because I was afraid I wouldn't run out of time. Now I think I'm probably going to be just fine. So, okay, so let's take a break. I'm going to pause the recording here and I'm going to get our quizzes together. Okay.
Oh, the cow.
Okay, so this one, so I don't know if anybody noticed, but Tana, you guys have Tana in clinic with you. What's her last name?
Spencer.
Spencer, so Professor Spencer. So or instructor Spencer. So she came up and talked last year about cancer, and it was really good. And then I just totally spaced asking her. So yesterday morning, I was like, "Hi, Tana, any chance you're available Monday morning?" And she's like, "No, I work." And I said, "Oh, shoot." I said, "My fault." And then I thought, oh, maybe I'll move cancer to another week so she can come in and talk. But you guys have her in clinic, you can just ask her. But then she works Mondays and and then the rest of the month, the semester is very packed. It just didn't work out. But mostly a lot of the stuff is overlapped. She did do a different looking PowerPoint. This is just the one that I've used through the years. But the one like total like mind-blowing thing that she said last year that stuck with me is that, we talk and you'll hear a lot about it in the dental hygiene realm is magic mouthwash. They talk a lot about it for cancer patients. And I think I even had something about it in pharmacology, so I might have even needed to update it there. But basically, she said, because she's gone through this whole extra training, oncology training, that she did through a educational place. I can't remember what it's called, but anyways, um, they don't really recommend magic mouthwash. And the reason is because it varies so, and this is true, it varies so much from pharmacist to pharmacist, compounding pharmacists, physicians, oncologists who think they have a great formula. And what they have found is very oftentimes it can be very acidic because of the different medications, and that sometimes it's exposing them to something they don't need, like an antibiotic, that's like they're using it as a preventative. But overuse of antibiotics, they worry about antibiotic resistance. And so really the latest literature has said that the best results for dealing with mucositis for patients who are going through cancer treatment is just good oral hygiene, gentle cleansing, and then just frequent rinsing with like a sodium bicarbonate mouthwash. So just something that sort of neutralizes the acid of the mouth, gentle cleansing. There you can do things like milk of magnesia or something that will kind of coat kind of a balanced something that would help with like inflammation and things like that. There are a few things like that. And if they're dealing with really horrible pain, there can also be like rinses, like lidocaine rinses. But for just maintaining, for preventing mucositis or a mild case of mucositis, it's just that rinsing with salt water and baking soda. That's the main thing. So I like jumped all the way to that just because I was so excited. I didn't want to forget it. But that was one of when she said that, I was like, what? Because that's just like the most common thing that you hear is magic mouthwash. It might have antifungals, antibiotics, lidocaine. It's like a mix of all this. It's like a cocktail. And and really, it's just not actually the best path forward for patients dealing with chemotherapy, especially if they are going to have head and neck, something with the head and neck. All right, so the objectives after that little spiel, explain terms related to cancer therapies, oral health care for the cancer patient, discuss risk factors associated with cancer, oral cancer, introducing common locations for oral cancer. Some of this will be review for you guys. We'll talk a little bit about the different kinds of therapies. There's way too many chemotherapeutic agents to even try to memorize drug names. So that's just not part of what it is. It's more like categories of treatment is more of what we're going to talk about. Identify common physical and oral signs and symptoms associated with cancer therapies, describe management of oral complications, explain the dental hygiene process of care for clients with cancer, including development of a care plan for before, during, and after. So it sort of just highlights like this is sort of like with the patient that's going to have an organ transplant. This is sort of what you want to think of beforehand. This is sort of what you're going to be focused on during, and this is sort of what you're going to be focused on after cancer treatment has concluded. So this is just sort of an outline of what the objectives are covering and what the slides are. We'll do some terminology, some cancer types and signs and symptoms, some therapies, common oral complications, and then some process of care discussion, and then what's in your clinic manual, the university guidelines. So assessment of a cancer patient. So this is sort of like the human emotional piece. So first you want to sort of know what is their current oral status. So this is sort of thinking about them before this is like a little pre-thought about how you would approach a patient that comes in and any changes in your medical history. Well, yeah, I actually like just got diagnosed with breast cancer, or yeah, I just got diagnosed with lymphoma, or something like that. And it's like, oh wow, but I haven't started treatment yet. We're going to start that something next week, and then something else is going to happen the week after that. And they're sort of like in this place of like, oh my gosh, like just like shock and fear, and just all of a sudden their world is totally different. Tons of appointments. What's the right course of action? So they have all this stuff to deal with. So you want to go over their health and dental history, and you're going to review care and their dental experiences that it says dental experiences that were painful. But really what this is really what I should probably have said here in the PowerPoint slide is you want to really, if you don't know this patient well, if maybe some other hygienist sees them, or maybe they're new-ish to the practice, or maybe you're new to the practice. Maybe they've been there forever, but you're new. You just want to get to know them and, really study like, okay, what's their oral health status? What do they need maybe coming up? Or, what are some things we want to think of? Historically, how have they been for their different risk factors? Have they been very high caries risk? Have they been like the model patient with just like a beautiful mouth and they've never had any problems at all? So it's just sort of taking a kind of a holistic look at your patient, anticipating that they're going to go through something really major. So interviewing the patient with a cancer diagnosis. So you want to understand how they perceive the disease, like what's going through their mind. Undoubtedly, they're just like maybe in a state of sort of shock, maybe, or just they're trying to process it. What are their sort of overall beliefs? How are they going to handle it? You could have somebody in your chair that's like, I'm not doing surgery and I'm not doing chemotherapy. I'm going to a naturopath and we're going to do X, Y, and Z. And it could be so non-traditional. And you could just as easily have that patient in your chair as opposed to someone that's like, I have surgery scheduled for next week. I have radiation scheduled for the week after, and then I'm going to start a 6-week course of chemotherapy. So it could be, any of those. So just finding out like, oh gosh, what's going on with you? What's going to happen? What's your, what do you think how you're going to move forward? If you feel like it's stressing them out, don't grill them. Use your intuition about, a conversation and their comfort level. Talking about coping strategies, their social support, who's around them to help them. Oh my gosh, that sounds like so much. Who's around you to help you keep track of all those appointments and sort of like be there, and you just talking to them, and you might be opening up a can of worms, but you just sort of to be again an empathetic, sympathetic ear, and you'll learn a little bit about their understanding of almost what they can handle when it comes to the oral health aspect, because that's really what you want to get at, is you want to give them a sort of a cautionary tale about what is going to become an increased risk for them. And so by getting them comfortable with you, by discussing it with you, now you have a window or an open door into saying, well, I care a lot about you in this process, and I want this to be really successful. And one thing we know about cancer and the treatments is that it can cause some oral health effects, and then blah 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 blah. Um, and so that's why you're kind of spending this time to and you might not even, who knows, maybe sometimes you might not get to the cleaning if you spend a lot of time on those discussions, or you might just get a little bit, and then you might need them to come back for a next week or something for their actual cleaning. If you took too much time, not too much, I shouldn't say it that way, but if you took extra time to sort of educate them about what might be happening. Yeah.
Same, they're getting treatment for cancer, or would that still?
Yeah, I am so glad you said that, because I start out with the ASAs, and then I think once I get to about this week, I forget to put it in. So yes, I think like if they're in cancer treatment, but we should verify that with we should go into the clinic manual and just see what it says, because I think it says it in that little thing. But I'm pretty sure that if they are in a very weakened state through like chemotherapies and things like that, that they go to a ASA3. And I should update that with obviously the same thing with organ donation, but I should have put those on the PowerPoint. So some terminology that you're just going to want to sort of be familiar with. A lot of this you probably already are, but cancer is obviously not one single disease. It's just a big umbrella term of like, crazy, uncontrolled proliferation, cells gone crazy, and starting to kind of hijack the body using, different blood sources and getting their taking over areas and causing issues because the cells have just multiplied. The regular system of like apoptosis, where like cells sort of die and then get sort of eaten up, and it's malfunctioning. So there's like excessive growth, and so all kinds of different, but it happens in different ways in different body systems. So cancer, abnormal or unrestricted growth of cells that can invade and destroy surrounding normal body tissues, sometimes spreading to other parts of the body. And that's obviously when it does that, it has metastasized, or that's metastasis. It can be benign, which of course that's what everyone hopes for if they have a lump or a tumor or something. Circumscribed, encapsulated, usually grows slowly, and then composed of cells that resemble the tissue that it arised from. And so it's sort of just like the body walls it off, sort of like you get some crazy growth, but the body kind of deals with it. And that's more of like a benign tumor. A malignant neoplasm is the bad diagnosis. And so that would be infiltrates locally, but has the potential to spread into other systems. And it can, go into lots of different sites. Cells are atypical, dysplastic, and may not resemble the parent tissue. Did you look it up?
I don't know, but that's the same, about cancer, but it says people undergoing dialysis or stage.
3.
Yes.
Okay, so that I can update. I'm gonna assume, I'll double check with Sarmiento, but I'm gonna assume that if they're in cancer treatment, that would put them at a 3. That would be my educated guess. But I'll double check with Sarmiento just to see. But yeah, I mean, once they're sort of through with treatment, and if they're, in remission, and it's been, 4 years post, they likely maybe could go back to a 2, I would assume, but I will double check with her. That's a really good question. Mm-hmm. So metastasize, spread to distant sites. Oncology is the study of cancer, while the oncologist is their cancer specialist. So just slightly different terms there. Everybody knows what increases your risk of cancer. In general, it's a lot of lifestyle things. There's so many pollutants in the air and the water and the food. And then on top of that, we choose to, smoke and drink and eat crazy things, and not always exercise. And, there's just so many. But then there's also viral. There's a lot of talk now about HPV. In October, we're doing a CE, the whole faculty are doing a updated CE on HPV and increased oral pharyngeal risk. Genetics. So, if you're in a family that everyone develops cancer at some point, then obviously that's a genetic predisposition. There's always that, and I always say it wrong, so I have to think about it, but there's the I'm not going to say it right now that I put pressure on my brain, but it's like it's something about like you know, your genes load the gun, but your lifestyle pulls the trigger. So it's like you might be predisposed to some of these. I know, like that's a horrible reference, a gun reference, but it kind of it makes sense though. You know, like you could be predisposed, but if you ate super healthy, exercised, and never smoked and drank, then you probably wouldn't get cancer. But then there's always the people that live like a model life and they die of cancer in their 40s. So, I mean, it's not something that it's not a science that's like perfectly, but in general, we know that there are carcinogens in our environment, in our lifestyle choices, and they do increase the risk in general. So, rise in oropharyngeal cancer. There's more people getting cancer that are adults under the age of 45, male and female. It used to be, you know, like 20 years ago, even, we just thought old men who smoked got oral cancer, and that was just about it. Well, if you smoked and drank in combination, that's who got oral cancer because it was actually a combination of the drinking and the smoking. So that was just what we got taught. Like that's who got cancer. Over 60, 65, drink, smoke and drink, they're going to get oral cancer or higher likelihood. Those are the only patients that we would see with oral cancer. But that's not true anymore, especially related to the human papillomavirus. Location, the throat, back third of the tongue, soft palate, side and back walls of the throat, and the tonsils. So sometimes it's really, you know, a little bit farther down than what we can see in our EOIO. And so, you know, that's, I think, why the subject is sort of broadening for patients who might be at higher risk. So early signs and symptoms of oral cancer, we all know our common sites because of where we check for with our EOIO. So back sides of the tongue, floor of the mouth, but it can also be like back around the tonsillar pillars. But those are going to be, you're more likely to see something on the back sides of the tongue, floor of the mouth, and the palate. But that doesn't mean that something can't show up on the palate. You're just not as likely to see that. So some things to kind of look for: swelling, lumps, any kind of a strange growth, especially if at first it's painless, like there's just some kind of a nodule, some kind of a growth or a swelling, and it's new and it's not necessarily hurting. Induration, we feel for that with the tongue, when we're feeling the lips, we're feeling for some kind of a hardness, just a change in the way the fish tissue feels. Again, oftentimes painless in the beginning. Erythroplakia, leukoplakia, a sore that does not heal after 2 weeks. So anything in the mouth that comes on, even if it looks really nasty, if it goes away in 2 weeks, cool, just some kind of an ulcer, something. But if you have even something small that doesn't go away in 2 weeks, that's really the time to get aggressively checking it out. I had a patient who had a purple, just like a little purple thing on their lip, and it was like right on the border, like vermilion border, is that what it is called? And I was always like, have you had this? He's like, oh, I think I've had, and you like I don't know, I saw him every 3 months, and I just look at it and never really changed. But the doctor came in one time and he looked at it and then he goes, you should just have that checked. And it was cancer. And it was just this little purple, like weird formed. It was like it wasn't uniform. It kind of had a scraggly lines and stuff. It wasn't raised or anything. It was, you know, just smooth like the rest of his lip, but it ended up being cancer. And so there was that. And then, but by far the worst one was a patient I had in Arizona. And she was a new patient to me. I'd never seen her before. She came in, I was cleaning her teeth, and she's like, well, I've had this sore in my mouth for a couple months now. And I pull out her tongue, not out of her mouth, but I wrapped it in gauze and I stretched it. And she had this sore that looked so similar to this picture. And I knew immediately. I was like, no, that's bad. And I didn't say it to her, you know, it was like this internal, like, oh my God. Because you just feel so bad because the chance of it being nothing is very small. And so I said, oh, well, you really need to have that checked. And she's like, yeah, I know, I really do. And, you know, she felt all of a sudden like it was not good. And I think she knew that, but she was trying to just be like, hey, it'll go away. And it just didn't. And so she'd had it for, I want to say she'd had it for months. I can't remember exactly how long, but like probably close to a year. She'd had it for a long time, way over 2 weeks. And so I think she might have come back one more time to see the dentist to have some cavities filled and confirmed it was oral cancer and she was starting treatment, but I never saw her again. So I don't really know, what happened to her, but you'll notice when you do your EOIOs that, normal things look normal and weird things look weird. And that's why in the beginning, when you're learning all the EOIO stuff, you're like, what does a normal thyroid feel like? Well, I don't know. But when you feel a swollen, spongy thyroid, you're like, oh, or when you feel a lump, you're like, oh, that feels different. So anything that's all you're getting to know is normal, 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 normal. Okay, that's not normal. So that's really what it is. And you won't know what it is. You'll never know what it is without a biopsy, but you'll just know instantly that's not normal. Okay, so cancer therapies, the goal is to remove or destroy cancer cells in the body. So some types of cancer treatments are obviously chemotherapy, bone marrow transplant, take out all somebody's bone marrow and put in brand new bone marrow. Major treatment, radiation, surgery, blood transplant, hormone therapy, target therapy. I'm not totally sure what that means, but I think sometimes they're targeting they have all kinds of different new, like crazy new technology that they're doing. Stem cell transplant. There's just a lot of research in cancer treatments. And then, of course, biopsy is the surgical removal of a part or all of a lesion, trying to find out what exactly they're dealing with. So treatment oftentimes they're trying to get it more targeted, but the part about it that we don't like is that when you have cancer treatment, you're literally killing healthy cells along with the cancer cells. And that's why they're trying to get, better and better drugs so that, you're just trying to survive the cancer treatment, really. Like you kill the cancer, but don't kill me. And so it's a very toxic way of treating a condition, but it's necessary in some instances, but there's a lot of research in that area. So hopefully it'll get better and better as time goes on. Okay, so for chemotherapy, there is an increased likelihood of sepsis, so just like blood infection, the patient getting very, very, very sick. Periodontal disease, obviously they're very weakened. Infection in the mouth could run rampant. Pulpal disease, again, so other dental concerns, pericoronal disease. So just in general, the mouth, because cell turnover is so fast in the mouth, there's a large blood supply in the mouth. So it just puts the mouth at a risk for infection and all kinds of things with during chemotherapy. So most common complications would be infection, and then this myelosuppression, the suppression of the bone marrow, which is our immune system, right? All of our major immune system comes from bone marrow. Other complications, electrolyte imbalance, bleeding, hemorrhaging. There can be changes in platelet activity, coagulation, acute toxicity. So we have the nausea and the vomiting, which a lot of people think of when they think of cancer therapy, photosensitivity, central nervous system dysfunction, hair loss, alopecia, and then poor nutritional status. So either just not absorbing nutrients as well, or just not being able to eat. Like that's a hard one, especially if someone has mucositis, really bad mucositis. Eating can be very, very, very painful. Bone marrow transplant used to treat hematologic diseases such as aplastic anemia, the leukemias, different lymphomas, neuroblastomas, so like a tumor in the brain, immunodeficiency diseases, and some solid tumors. So again, they're just like putting in a healthy bone marrow. And it's quite a process. I had several slides. I used to have slides on graft graft versus host disease. Like it was basically like within the first 100 days, you have these kind of susceptibilities. If you make it past this, these are some other susceptibilities. But it just was so much information that I kind of took it out. But again, it's one of these situations where you can learn. This is what continuing education is for. You can do a lot like what Doctor, she probably love that, but Tana's what Dr. Tana says, she has really become like an expert in a lot of oncological topics. And you could go work for a hospital. There's hygienists out there that work in oncology, because there is a lot of overlap with what hygienists can do. So there's so many interesting things that you can further your knowledge about, but sometimes it's just too much for one class, one lecture. But anyways, so here are some oral considerations for chemotherapy and for bone marrow transplant. So oral mucositis is by far the most common thing that you should just be really aware of. Anytime patient is in any kind of cancer treatment, they're at risk for this, but obviously if it's above the head and if it's in the head and neck region, it's gonna be even probably more likely. But just really understanding that they are at risk for this no matter what, even if they have maybe breast cancer, they could still be at risk for oral mucositis. Burning pain interferes with talking, swallowing, nutrition. Some patients can have it so horribly bad that water hurts. Like, and of course, these are the patients that probably have oral cancer. There's a lot of radiation happening. There's a lot of, all of the cells in their head and neck are being targeted with the chemotherapy. But it can just be like utter misery. There is this woman that had oral cancer. She was concerned about it. Her name's Eva something. Does anyone know? She's like real, like feisty, bouncy. She's like a Broadway actress. Not really, but that's the way she comes across. And she goes in on the dental circuit, talking circuit, and tells her story. Has anyone heard of her? Eva? No, something. Okay. Anyways, you probably will, because she still goes around and does her talk, but she tells a crazy story where she tried, to say something's going on, and they ignored it. Oh no, that's fine, that's normal, until finally someone took her seriously, and by that time she needed to have surgeries, and she had a horrible experience with mucositis, and so she really painted this vivid picture of what her life was like when she was dealing with it, trying to eat. And you can find other, patients talking about their experiences similarly. But so that's one that we really want to sort of head off before it becomes bad. Neurotoxicity is a deep, severe bilateral pain that can be experienced, just nerve pain. It can affect, it can feel like bad toothache, and it can just be a side effect of chemotherapy. Infection, bleeding and hemorrhaging, saliva gland dysfunction, especially if there's any kind of radiation in the salivary gland areas, dental caries, especially if there's dry mouth, and then altered tooth development if it's a little one that has to go through chemotherapy. Oh my gosh, yesterday I brought Lola to the park, and there was this I don't know if it was a boy or a girl, because they had no hair. It was like, oh my gosh, it was just this little thing, and it was bald. And so I'm assuming they're under had cancer treatment. And they came up to Lola, and they had a snack, and they just were like handing it to her. And Lola, kids when they see things they don't see, they get awkward. Like, what is this child? And I was like, hi. And I said, say hi. And they were so cute, but they had no hair. No hair. Makes your heart just kind of break a little bit. Okay, so oral considerations. So this one here, so preventing and managing is the thing. So when you have a patient in your chair and they tell you that they're going to go through cancer treatment, that's basically your role is, okay, you're going to go through this thing. Let's get you prepared for it and keep your mouth as healthy as we can. So you're going to be talking about preventing mucositis, Maybe using more extra fluoride or some, if they don't want to do that, think about other things that they can use to just keep the oral cavity healthy. And so that's like your main thing. So you want to optimize, you want to keep their mouth healthy to help optimize the cancer treatment. Because if somebody ends up having horrible, like tooth pain or mucositis or something, and they're just like, they might end treatment early. They might be like, I can't do this. I can't do this anymore. And they might not be able to finish a full course. They might, just their morale, their whole outlook on life would just go down the toilet because if you're already tired, but now you can't even eat, like you can't even eat a smoothie without having your mouth feel like it's on fire. So just talking to them about prevention and sort of helping them know how to keep things healthy going into their treatment. So for mucositis, chemo may be toxic to the oral mucosa, cause edema, inflammation, ulcerations. Patients report burning pain, general discomfort. It can interfere with just all the things that your mouth does. So management for that is pretty simple, but they have to stay on top of it. So keeping the area moist and clean, and then so good as best nutrition as they possibly can, whether that's supplementing, just cutting out sugar, caffeine, anything that could possibly harm them, and just trying to load up on fruits and veggies, maybe smoothies before any kind of signs and symptoms show up. Just get them, getting the best nutrition possible. Control secondary infections. Patient rinse with saline, sodium bicarbonate, maybe a couple times a day. No irritating mouthwashes. So if they think, oh, I'm going to kill the bacteria and use chlorhexidine, no, that's a bad idea. So nothing that's has any irritation. And then this last one, use mild topical analgesics, may progress to systemic analgesics if necessary. That's sort of like just a caveat. Like sometimes there are some, especially for oral cancer patients that have, a lot of radiation, and if they're just in pain, the doctor might prescribe some kind of like a rinse with lidocaine in it or something. This basically just says the similar things. Early detection and treatment of oral infection is really important. Good oral hygiene is super important. Frequent rinsing with baking soda or salt. Biotine, as long as it's like an alcohol-free, very, very gentle, soothing mouthwash, just nothing with any harsh, no Listerine, no, chlorhexidine. I don't even know about like what's that one? Cyclosine, something? Cyclosine? I don't know. You guys know what I'm talking about. I know. Closin? I don't know. Whatever that one is. Keeping, if they have a partial or they have a denture, keeping that very, very, very clean. And then let's see. Use of prescribed topical anesthetics with caution to avoid anesthetizing soft palate, aspirating food. This is just some of these are very specific to like maybe a specific situation. Over the counter, prescribe systemic analgesics if necessary. Avoid irritating, rough textured food, avoiding spicy food, just anything that would seem like it could be irritating. Use of perioral moisturizers, as directed by the oncologist. So prevention and so that's a lot of what you would talk to the patient about. You'd say, I want you to know going into this that these are a risk factor for you. And I want you to get on a good regimen now before you're tired, before you're overwhelmed with appointments, just so that we can prevent some of this stuff down the road. Neurotoxicity, damage to nerve tissues caused by the toxic substances, the different chemotherapeutic agents. They're, as much pharmacology is derived from plant alkaloids, and some of them are toxic to nerve tissues. So that can cause that deep pain that feels like tooth pain. Again, infection, they're going to be on immunosuppressants, and the chemotherapeutic agents can suppress their immune system. That's going to intensify mucositis. So these are just things, that to watch out for. Management oncologists should decide the safest time to schedule a dental hygiene appointment, may recommend pre-med. So it depends on, again, sort of how severe, if they're even able to come in. You probably are going to see them before they start treatment and then after treatment's done. So I would say if it's somebody that you've seen for a while, I would give them a call when they're about due. And or even like, you could say, I want to call you like once a month and just see how your mouth is feeling. Make sure you don't have any mucositis, starting. But chances are you're not going to see them when they're in active treatment. So you're probably going to see them after they're done because it's just so overwhelming and it's so many appointments and they're so tired. But if they do come in during treatment, you have to find out if they need that pre-med or not. The stop brushing and flossing is something that some resources say but I think that that's a kind of a crazy statement. Just know that when you go out into the world, you'll find there's always resources and people will say different things. It oftentimes I think it stems from like, being too rough, brushing too hard, irritating the delicate tissue that's very sort of being highly affected by the chemotherapy, and you don't want to make a bunch of damage. But soft, extra soft, extra gentle toothbrushing from the start. Maybe either like a gentle water pick or something instead of like, you can think of different ways to approach oral hygiene, but it goes against my intuition to say don't do it. You just might have to sort of tailor it to be a little bit more gentle, especially once they're in full swing of treatment. Denture wares, they need to take them out. They need to soak them, keep them clean. You don't have to memorize these numbers for the thrombocytopenia. Just know that hemorrhaging thrombocytopenia it can be something that some patients with chemotherapy and different types of therapies have to worry about. It's a reduction in clotting factor, low platelet. We talked about that last week. Consult the oncologist if you're worried about it or if you are worried about the excessive bleeding. And yeah, if dental procedure is imperative, like they need to have something, that's more on the dentist side. If they have to do some kind of a surgery or an extraction or something, they would consult with the oncologist. Salivary gland dysfunction is, of course, a major thing that we're worried about. On top with mucositis, we're also really worried about that. So dry mouth, thinking of ways to help patients combat dry mouth. We've already talked a lot about that in general. Nutritional counseling, fluoride trays, ClinPro, staying hydrated, talking to the family members to really encourage them to help the patient, and then all your oral hygiene techniques. So for radiation specifically, we know radiation is ionizing radiation. And so they could either get it from like an external source, or sometimes they will implant something that's like radioactive. And then examples for cancer could be oropharyngeal lymphomas, salivary gland tumors. Definitely a lot of damage to the normal cells, maybe acute and resolve after therapy. It depends on how much damage. If they've had tons of damage to their salivary glands, they're probably always going to have some dry mouth or some hyposalivation. And if they just had mild, it might rebound. There's a potential for their body to repair itself. These are just some acute versus chronic. A lot of these we've already covered, but while they're in the treatment, obviously they're going to have xerostomia, possibly loss of taste, mucositis should be at the top, dysphagia, difficulty swallowing, secondary infections, trismus. So again, that, hard difficulty opening, impaired nutrition, hearing loss. If the radiation is close to their ears, it can affect their hearing. And then of course, fatigue. For chronic, of course, there could be chronic xerostomia, chronic alteration in taste, this telangiectasia, spider veins, and I'm going to say it wrong, febrile mucosa. It's just it's like the radiation damaged the veins, the blood vessels, and the mucosa. So it made it, you know, how as we age, our mucosa gets thinner and more fragile. So they almost had sort of a rushed aging process sort of in their mucosa. Continued fungal infections, osteoradionecrosis, if they're on a bisphosphonate, or it can also happen just from radiation. Rampant caries, muscle fibrosis, TMJ disorders, trismus, altered tooth and jaw development if it's happening with children. Another type of treatment is surgery. They might have a jaw resection if they have oral cancer, head and neck, or some, oral cancer. They might have part of their mandible resected. Sometimes they will actually replace part. They'll take part of a rib and replace the part of the mandible to build up some more structure. They can do some kind of secondary surgeries. But of course, with surgery, there's can be all kinds of complications, specifically physical. So it can be like your landscape is totally different. So you might have like a dip that collects a bunch of, food, and plaque builds up and cells build up there, and you got to clean out this new funny little dip. It's not like your typical oral landscape that we're used to. So infections, airway obstructions, fistulas can be hard to clear out and go away, heal up. The necrosis, impairment of swallowing, hearing, vision, smell, speech, anything, depending on what they had to like remove, to how big the cancer was, the location of the cancer. Compromised nutrition if they just can't eat as well. Drooling, do you guys, anybody know Val Kilmer? Remember Val Kilmer and get oral cancer? He was constantly dabbing like before he passed away, he did a fair amount of like public stuff. He's constantly dabbing his face because he like drooling a lot. So, there's just all these complications, malocclusion, temporomandibular dysfunction. The facial deformity is, of course, psychologically very hard to deal with. So, depression, anger, stigmatization, all of those things would be very difficult to deal with. So a lot of times for the management of that, you just have to realize, like, if you have a patient in your chair that's had some kind of oral cancer surgery and things don't look the same, very oftentimes the biggest hurdle that you're going to have to get over is it's okay to touch inside their mouth and figure it out. It's not going to look the same. It's not going to be your normal thing. So, maybe do it with the dentist. Be like, what's this? Like if you see like some kind of like a, exposed bone or something, maybe they have osteoradionecrosis and there's a little piece of exposed bone and you'll be like, is that tooth or is that their bone? And don't be afraid to like figure it out and learn, because that patient should come in, on a regular basis. And it'd be nice if they had some continuity of care with the same dental hygienist, who isn't afraid to deal with their mouth, and touch their mouth and figure it out and help them figure out how to keep it clean. So assess for oral irrigation and comfort, empathetic listening and stress reduction. OHI, it's just gonna have to figure it out. Like, what are we dealing with? How do we have to alter our OHI? Where is things accumulating? How can we keep it clean? Rinsing, irrigating, water picks would be great, because especially one that they can maybe use like, in the shower or over the sink and just let, it flush and drain. Saline rinses, cotton tip applicators for debridement, sponge swabs, gauze. They still obviously could use a toothbrush for any areas where they have teeth. I saw this one picture come up on one of these dental hygiene things where this guy had this tongue that looked almost calcified. It was like crazy looking. It looked like his tongue was like calcified. And the hygienist went around to nursing homes and care homes and stuff. And it was just because he had a feeding bag. And so he didn't masticate. He didn't like use his mouth for anything. And so all the cells just built up and built up and built up. So she went in and like scraped his tongue and like cleaned and bless that woman. She's got like a halo around her head. And she just kept cleaning it and cleaning it. And she showed before and afters. It was crazy because everyone was like, what is that? Like you just wouldn't even necessarily know how to approach it. And for whatever reason, she'd gotten the right education or talked with doctors. And that it was just buildup of like plaque and cells and things like that. Anyways, okay. So prosthetics after surgery, you guys have seen the abturators. We've seen that for cleft palate. The other use would be patients that had oral cancer. It's going to depend on the shape of the oral cavity. We've got to think about the dryness of their mouth, the mucosa, just keeping it clean, keeping everything moist. Maxillary difficulties after surgery, nasal voice quality can change. If there's a communication in the sinuses, that would bring that thick mucosa down. That could be troublesome. Facial disfigurement, difficulty with speech, swallowing. And then for mandibular difficulties, usually there's added surgeries that need so that they can have some function. Bless you. Okay, just one slide on the bisphosphonates. The IV bisphosphonates do put patients at a higher risk for the ONJ, the necrosis, if they have any kind of like bless you, any kind of a surgery, or maybe even it can happen with other things, but usually it's surgical. These areas, I went to a class over the summer where this lady just exclusively deals, she's a dentist, and she exclusively deals with patients that have different kinds of necrosis, oral necrosis from bisphosphonates. And she said that usually what happens if you ride it out long enough, that bone fully dies and detaches from the area and comes away like in a chunk. And then a lot of times it'll resolve. And she said a lot of dentists don't understand that, but it can take years. And and I was like, wow, that's really interesting. It's kind of like if someone has tooth extracted and there's like little splinters that come off, and maybe 10 years later, a splinter comes up out of and it's like, oh, I had a tooth extracted like 10 years ago. And what's this? Oh, it's a little piece of bone that came off and made its way up. But she said that is very common to happen, which I thought was really interesting. I had never heard of that before.
We cleaned them?
Yes, that was the other, such a good question and totally a common, yeah, like totally a common sense question. And I just feel like that's the kind of thing that people don't say out loud. And that's why I like this class so much. But she's like, yes, you go there, to help the patient know how to clean it, just gentle, like, because it'll accumulate plaque and stuff. So just gentle cleaning around it, and help the patient know that it's okay to clean it. And it's not something like don't touch it, because it's bone. It's going to be not what's uncomfortable, I think, is the inflamed tissue, not the bone won't have any feeling. So bisphosphonates, specifically the drugs, a lot of times for a cancer patient, they're trying to get excess calcium out of oh my gosh, is it time to end? You guys, how did I run out of time? I thought I was doing so good. I was doing so good. Okay. I didn't even get to the process of care. Okay, you guys are just gonna have to read it on your own. Yay! If you have any questions, ask me. But read those slides carefully. It honestly is like common sense, and mostly it's helping prepare the patient and then making sure you're not doing something if they're in a very fragile state. That summarizes it. How did I run out of time?
No. I was done and I was shocked too.
Were you just as shocked as me?